Thank you to Sakib and to Christoph for the invitation. I'm very happy to be here. I'm just going to give you just a few details so you understand the concept behind what I do. This is my disclosure. So you just saw what Christoph did, and basically it's the same concept. We go trans-Kambin through Kambin's triangle, and this allows you to bypass the exiting route, right? I use a facet sparing approach most of the time, so you have less blood loss, less pain, and actually the advantages are you can have an opioid-free postoperative recovery, so the patients require very little postoperative control. This was the very first time my father did it. It was back in 2010. We haven't found any literature of a cage being done endoscopically before, but so it's been quite a long ride since then. We also used other kind of devices even before that, like this between device. And well, we've been publishing a lot about this technique in the last years. So you can look it up if you're interested. But we have seen like the limitations of PTLIF. So we have seen an increased acceptance, and yet the first problem is that you need endoscopic visualization. So either you're an endoscopic surgeon, you have the equipment costs, you have the learning curve. It's time consuming because it takes some time with tiny instruments. So this is a limitation, and we would like to expand the idea of the trans-Kambin approach to also non-endoscopic surgeons. Then the problem also from endoscopic PTLIFs is that you have small cages, right? They have to fit through a tube, so you need actually to use a specialized cage to actually get it through. And this usually implies an expandable cage to increase a bit of the footprint, which has a mechanism and makes it more expensive. So the goals that we set when we were there about 4 or 5 years ago was we wanted to actually find a way to do this with endoscopy being optional, so being purely fluoroscopic, like putting percutaneous screws. And we have to watch out with the postoperative anesthesia. We wanted to use open surgery instruments so we can be time efficient doing the disc preparation. And we wanted to use any kind of cage, especially large footprint cages. And the concept behind this, as you can see here, so there's a facet sparing or the facet resecting TLIF, right? This would be like the more regular MIS TLIF. And the more medial entry point also implies some risks, as you know. Well, it's quicker with the TLIF. You take out the facets with a chisel. But this is a nice publication, recent publication from a Swiss group, and they found that they have a 10% of dural tears going that medially. Okay, probably most of you will say, oh, I don't have that, but well, it's up there and it could be an issue. So the idea of the trans-Kambin approach is that you're actually going more lateral because you're preserving the facet, right? And the problem with that is that the thing that is most exposed, if it's facet sparing, it's the exiting nerve root. If you go facet resection, then it's more the traversing nerve root, okay? So we have to protect somehow the exiting nerve root. That's the idea. And that's the whole idea behind the concept that I'm going to show you. So what we did is we designed a dilator. We call it the fusion dilator, which you slide through percutaneously, like you know, with the like in the endoscope. And once it's inside there, it splits in 2 stages. And we remove one of the stages. And what you have is a half a tube, not a full tube. So you are not constrained by a diameter of a tube. And at the same time, this sheath is protecting the exiting nerve root, like you just saw on the diagram. So that's the idea behind it. And of course, we're always working on the caudal aspect of the foramen, so we're mostly far away of the exiting nerve root. That's the whole idea behind it. It's actually quite simple. Then we do the foraminoplasty with some reamers using just a fluoroscope, but we have the sheath protecting the exiting nerve root at all times. And then you can use, because it's an open tube, you can use open surgery instruments to do the disc preparation. You're not constrained by the tube itself. And this is a patient where I did both approaches. I did L5S1, I did the trans-Kambin approach, and this is the disc preparation I got, and the levels above, I did 3 levels with OLIF anterior to psoas approaches, and you can see that you can actually do a good disc preparation with the trans-Kambin approach. And like just Christoph showed, you can, if you want to, optionally put in the endoscope and look if your end plates are well prepared, okay? So this is the proof that you're doing a good job or not. So you have to be courageous enough to actually check back on yourself. And this is the way. So again, it's no tube, so you can put in big cages just using the scope. And you can expand them if it's an expandable cage. This is usually how it looks like, 1 level, 2 levels. And what I did is, as many people were asking me, yeah, well, that's nice, but actually, how does it perform? Like, does it really work? And so I said, okay, what is, for me, my gold standard is ALIF. When I have a patient in my practice going through the door, the first thing I think is, why not ALIF? That's the first thing that goes through my head. But not everyone is suitable for an ALIF. So this is the TLIF cage that I have used for this study, but you can use all kinds of cages. And you can see that compared to an ALIF cage, well, it's a huge TLIF cage, right? ALIF is always better, but this was a huge cage. Demographics, it was 87 patients, 2 groups, 44 and 43. And preoperatively, no differences in the scores. Postoperatively, no difference between the groups. So both groups fared well. VIS back. We had a 2.5 years follow-up, VIS leg, ODI. So both groups were comparable in that sense. We also did some radiologic comparison. So standing X-rays, this was an ALIF, pre-op, post-op. We checked all the parameters. And it's a lot of numbers. Basically, the only difference that we found is that ALIF is better in restoring segmental lordosis. So I got almost 8 degrees of lumbar lordosis, segmental lumbar lordosis with an ALIF, and half of it with a TLIF. But still, for being a facet-preserving TLIF, that's quite okay. So 3.5 degrees is fine. Well, if you want to do a deformity, if you really need to increase lordosis, then maybe you go for the ALIF. So complications. Postoperative dysesthesia is an issue, all right? But interestingly, it's also an issue for ALIF. And this is something that is not well studied or well known. So we had a non-significant difference in postoperative dysesthesia between trans-Kambin and ALIF. And how is that? Well, radiculitis, as you know, this is the pain sets on 2-3 days after surgery because it's an inflammatory process. Usually it's a DRG, dorsal root ganglion. You get some inflammation. The patient is happy, goes home, and after 3 days they call you and it's in agony. Okay. So usually you cannot pick up anything in the neuromonitoring, and with ALIF, you get that because of indirect distraction. You're putting big cages in, so you get a distraction of the nerve roots. And so there's several papers now out there reporting 34%. These guys reported 18%. This is a very recent paper from Brown with a stretching, they call it stretch neuropraxia, with 28%. So between 18 and 35%. And this is what I got too. I got 21% with the ALIF. The good thing is it's temporary. It always fades away, but it takes 6 weeks, 7 weeks median, and during that time, the patient hates you with all of his guts, okay? So usually we give them pregabalin and some steroids, and that usually allows you to overcome and to bridge over the time, but it creates a lot of noise in your follow-up. So this is something that you have to be careful about, also in the trans-Kambin approach. We got a good fusion rate for both groups, over 90% with a CAT scan at 1 year follow-up. So if you want to look it up, we just published a study in the Global Spine Journal. We have 2 different studies that we published there, so it's all there. The good thing about the system, we'll be using today the Axellus cage, the Flarehawk. I've been using all of the kind of cages, big cages, small cages. The tube is not hindering you. And we've had now a few groups over the world. This was a group in Germany who just used it. We had this guy in Cyprus putting in the cages with the system. Then we had this gentleman, very experienced surgeon also in India, and here you see him putting in the dilator. So yeah, it's catching on a bit. So I think it's a very interesting procedure because it's full percutaneous. You can learn it without being an endoscopist. It has a short learning curve. You can do a time-efficient disc preparation, minimizes dural tears because you go more lateral, minimize risk of infection, of course, and you can use most of the interbody cages. And of course, this increases the costs. And that's it. I'm going to show it right now in the cadaver lab. Okay.
While we're waiting for Christian, that dilator is pretty interesting. I think I spoke to Pat before. Pat, is Pat here?
Yeah.
Pat, how different is that dilator from the Harrison retractor that you typically use?
Yeah, so the Harrison glider system is a collapsible tube. So basically it's collapsible so that it can medially, be inserted into the Kambin triangle once a complete facetectomy is done. And then the medial blade will retract the traversing, and the lateral blade will be retracting the lateral exiting nerve root. So because it's a compressible, like as the cage go in, it will transiently just dilate these 2 nerve roots, and then once it's in, then it just collapses back down so that there's no real, retraction time for these nerve roots. So it's fairly analogous to tubular, but I think the fact that this retractor is collapsible, I think it makes it safer than a tubular TLIF, in my opinion. So I think, we kind of talked about, what endo TLIF is not an endo TLIF. There's so many different ways to do it. And but I think for some, we do endo TLIF similar to tubular TLIF, but that's because endoscope is the best tool in our hands. We don't just do it to say that, we are doing endoscopic TLIF. So.
Hey, a quick question I have, also for the rest of the faculty that we're waiting here right now is, what are the demands on nerve root retraction in a TLIF versus endoscopic PLIF? And I think, Mark, you probably have a lot of experience in that. Do you want to elaborate on that?
All right, let's go. So I'm going to do basically the same thing that Christoph was doing. Can we have a shot here, please? So this is the L4, L5 space, which I'm going to go now and make another shot, please. Okay, I measured before the distance. I will be going a bit more lateral than Christoph, basically because of the slide that I just showed you. So usually it's a 55-degree angle that I'm usually going in. Shot, please. So usually I try to go to the more caudal aspect of the foramen. Shot, that's it. We go to lateral. And I'm on bone now. It should be the SAP. And so depending on the type of cage that you will be inserting, if it's a small kind of cage or medium-sized cage, then you have always a buffer to work around it. But when you're working with a big cage, you have to be very precise because, as Christoph was saying, with endoscopy, so shot. So, and we have an AP, please. So I always check my entrance point with AP and lateral, because if I'm putting in a big cage, that this could give me some problems if I'm not exactly at the same place, because I'm going to use the whole disc space. Okay, shot, please. Okay, so I'm in the middle of the disc here. Can we have a lateral? And I'll go with the K-wire. So usually what I'm looking for is that I have what I call a symmetric view. So that I'm mostly at the middle of the disc in AP and lateral. Okay, so we are a bit steep here, but it should be fine. So now I go with the K-wire, and as you can see by the angle, this is usually about a 55-degree angle. I'll have the knife. Thank you. Okay. Okay. So, and then I go in with the small dilator over the K-wire. Okay, shot. This is it. So I'm inside the disc here, and now I'll go. So usually, if it's a collapsed disc, I would go with this like medium-sized dilator. This is a big disc, so we can go right ahead with the fusion dilator.
Hey, Christian.
So the fusion dilator.
Christian, can you hear me?
Can you see it? Yeah. So the fusion dilator has two stages. You can see this will be the protective sheath, and this is the dilator part, and it's very smooth,
Christian,
so it will not.
Question from the audience here right now. Can you hear me?
Say again?
Are there any instances where you try to visualize the neural elements, or do you always go in percutaneous directly in the disc?
Did you guys understand?
Do you ever
Yeah. I always go percutaneous unless it's a very collapsed disc or I'm putting in a large cage. Then I will start with the endoscopy and do the foraminoplasty endoscopically. Usually I try to localize the exiting nerve root and mobilize it. And as Christoph showed with the endoscope, but it's usually when I have only a very stenotic level or I have a very big cage to place. Then I check endoscopically. So I'm putting in the dilator with the sheath facing the nerve root. The nerve root is cranially, so it would be like that. So I want to protect it. So this is the insertion of my fusion dilator. Let me use a mallet, please. Thank you. So can I have a shot? Okay. So I'm already past the SAP here. So I'm just gonna go into the disc. Shot. Okay. So I'm almost there. And now what I do is I open up the stages, and then I'll just progress only with the sheath. So you can see the stages separating. Shot. Okay. And shot. So now I'm wide into the disc, and now I can take out the dilator.
That was beautiful. Can you tell us a little bit about how you position that sheath with relationship? Because it seems like it's a little bit turned with the end plates.
Well, the sheath is, so the nice thing about the design of the sheath.
Yeah.
So the
orientation that you prefer?
Yeah, so the nice thing about the sheath is that it's not oval. It's not concentric like a tube. It's oval. So it actually finds its own way inside the foramen. I'm not actively positioning it, but it just adapts to the anatomy. because of the shape that it has on the tip. So the whole idea of the design is that it's self-adapting to the foramen. So the nerve root goes like this, and the sheath is already protecting the nerve root. And I'm happy here with the position. So what I do now is I go in with the manual reamers. You can see this. This is a 4mm manual reamer, a 6mm, sorry. And I use the sheath. I call this a highway to the disc. So now, I mean, it's basically my work to the disc is done. And now I use this just to get through the SAP. Can we have a shot, please? Okay, so I'm almost here at the inside the disc. You can use it to prepare the disc if you want, but as Christoph said, you have to be very, very careful not to damage the end plate. So you have to be sure that your trajectory is parallel to the end plates and you're not going to hit the end plates. If you damage the end plates, that's where your cage will go. So this is something you want to avoid. So you can feel, I can feel the bone here, and then I'm inside the disc, please. Okay, I'm checking in the lateral. Usually you can control this in AP, but I'm checking in the lateral because if I'm going into the disc, I want to make sure that I'm not hitting the end plates. All right, because I use this also to like speed up a bit of the disc preparation. So you can feel the bone.
Christian, you're taking that, and getting some of the SAP as you get into the disc, and then taking some of the disc out. So it's doing two functions.
Exactly, exactly. So the main function of this is actually reaming out the SAP, but if your trajectory is okay and you're not going into the end plate, then you can also use this. You see, I have material here on my reamer, so you can use it to actually speed up a bit the disc preparation. But don't do this on your first case unless you're very sure that your trajectory is fine. And so I'm going up millimeter by millimeter. We're at 9 now. Okay, shot, yeah. And this helps also to get through the annulus. Shot, please. Okay, so this is where we want to be careful not to go onto the end plate. Okay, next one, please. So the cage we're placing is a 9mm cage. So this is a 10mm reamer. I usually go 1mm above the cage size. So this should suffice to get the cage in, right? So, okay, shot, please. Okay.
Christian, are these reamers both forward cutting and side cutting, or mainly where are they cutting?
Say again?
Are they forward cutting as well as
yeah,
side
so
cutting?
these reamers are very nice actually because they are blunt on the tip. So it's very difficult to actually hit something, and they are cutting only to the right side. If you go counterclockwise, they don't cut. They only cut when you're going clockwise. So you have a very good control of what you're actually doing, you know, and you can feel the bone. You can cut in, and when you're retrieving the reamer, it will not cut. Okay, but the nice thing is, as I have the sheath here, my exiting nerve root should be protected at all time. So, and now I've finished the foraminoplasty, and now I'm going in with, well, you see, these are regular disc preparation instruments. This is not an endoscopic instrument. So I'm using just this to prepare. Shot, please. Okay, I'm inside the disc. And so I start taking out disc material. Here you go. And as I'm using regular instruments, I should be able to do this quite quickly. Okay. Okay. Shot, please. As I'm doing everything percutaneously, I keep checking. I always say that I trust nobody, and I especially don't trust myself. So I'm always checking on the X-ray that I'm still inside the disc. You don't want to push through the annulus and go anteriorly. Okay, and so can we have an angulated forceps? Pituitary, yes, thank you. So again, this is quite steep. Let's see if we can get it in.
And Christian, with that retractor blade in, how are you getting to the inferior end plate of the rostral level?
Right. Let me show you. So we can take the end plate scratcher, the angulated. So the one thing that you want to try to avoid is pushing on the sheath, because it's a long lever. If you do like that, you will be actually pushing on the nerve root. This is something you want to avoid. So you really want to have your trajectory at the beginning to be as precise as possible. But then to get into, as we were saying, to get inside the disc, let's see if we can get this in. Okay, that's quite angulated. Okay, shot, please. Let's see if I can get inside. Okay, now I'm in. Shot. Okay, so as you can see here, now I'm at the caudal end plate of the cranial level, and you can hear the scratching. Shot, please. So you see that? And if I want to go to the other level, I just turn around and shot. There I am, and then I'm scratching here too. Okay. So the next thing that you have to be careful about is the more disk space you're actually cleaning out. So you can see how much I'm taking out. So it's a very nice. Where's the camera? Here. So you see, it's a big. Thank you. So it's a big chunk of disk that I'm taking out here. So the thing that you have to be careful about, of course, is the more you're cleaning out the disk, the more movement you will get into your sheath. Right now it's still well anchored, but of course, if you take a lot of disk out, then I'll go back to the pituitary. Thank you. Pituitary. Yeah. Thank you. Great. So. Here you go. Now I'm starting to get the big chunks out. So you can see you can do this pretty fast and get a good disc preparation. So let's see how well we're doing in terms of placing a cage. Can we have the spoon, the straight spoon? Let's see how far we are. Okay, can we have a shot, please? So here I'm in the interior part of the disc. Can we have an AP? So I always check before putting in a cage. I just want to be sure that I've cleaned out enough disc and that my insertion angle is fine. So let's see what the AP is telling us. Okay, so I'm past the midline here. I'm at the interior part of lateral. So this is actually not a bad position for me to place a cage. We will go now. This is 9. Okay, go back to lateral, please. Okay, so now we are using some disc spacers just to see. Okay, so shot, please. Okay, this would be a 9. Looks pretty good, right? Think so. So and it again it went. I want to show this again. So as we did a foraminoplasty up to 10 millimeters, this is a 9 millimeter instrument, and you saw how smoothly it just went into the disc. There's no resistance here. We're not pushing on bone. We're not pushing on the nerve root. So that's very important. That's why the foraminoplasty is so important. I think we could be preparing a bit more of the disc, but want to try 10? Okay. It's a big disc, but in terms and sake of time, I don't think we can. Okay, yeah, so I think this 10 is too much. I would go for 9. And I take the pituitary again, and then we prepare the cage, please. Okay. Okay. Okay, but as you've seen, I believe the nice thing about this is like, you can be very efficient, and it's very simple. So it's really not a complex system. It's basically a dilator, and the foraminoplasty with the reamers. So let me see if we have enough space. Can I have the knife? That's always a problem. If I do more than 1 centimeter, I'm becoming an MIS surgeon. I would like to stay an endoscopic surgeon, but a big cage requires a big incision, right? Okay, so here we go. So I'm using the slide as it helps me find the trajectory. Okay, so shot, please. Okay, so the mallet. Shot. Okay. Shot. Okay, now I'm inside. Okay, the cage is inside now. So usually what I do here now is I would remove the sleeve because I'm past the exiting nerve root. I'm not going to manipulate anymore. Shot, please. Okay, we're going to do an AP. Okay, we would just go a bit more far in. I like to go a little bit more above the mid shot. That's pretty good. Yeah. Okay, so we will have to remove this. Okay, right. And now we're going to expand the cage. You go to lateral, please. It's always more beautiful to see the expansion in lateral. And this guy's doing a great job. Okay. Okay, show me that. So now I'm going to start to expand the cage. Okay, shot, please. Okay, shot again. And shot. Okay, that's it. Shot. Okay, so now the cage is expanded. Basically, it has pushed in inside the cage, and we have an expansion. And now, counterclockwise, right. And then we take this out. Okay, here we go. It's nice, very nice. And this is for the graft injection. So one thing I always say with endoscopy, I mean, beginners look at the screen, and the pros, they look at your hands. And for me, this angle was telling me that actually this cage should be placed correctly. Okay, so always look at, not that much on the fluoroscope, but always look at your hands, right? And okay, I think I'm on the cage. All right. Okay. Like that? Okay. Okay. Like that? Like that? All right. Okay. Like that? Okay. Yeah? Okay. Oh, so that's the bone graft we're injecting now. We're backfilling with bone graft. All right. Okay, give me a shot, please. Again, I'm always controlling. I never trust no one, especially not the rep, especially not the anesthesia guy. Check, please. That's good. So you see the bone graft going in. Yeah. So I take this out. Everything? Okay. One more. Okay. And we'll go with a bit more graft again. Okay, here we go. And check. I think we had some graft going back. Okay. Yeah, that's it. And now, okay. So check, please. Okay, we had some graft coming out a bit, but well, that's okay. And then can we have the AP? That was a bit too much graft. So here I'm pretty much anterior, so that's great. And here you can see the cage is in the middle. We put in a bit too much graft, but I think the position of the cage is perfect. We're exactly in the middle. And, and as you have seen, usually in an OR set, that's the time it takes to put in a cage. So usually in 20, 25 minutes, you're done. Okay, that's basically it. So I hope you liked it. It's a very simple system, but it works well, and especially in cases like this. So thanks. Thank you, guys.
Thanks, everyone.